and thank you for joining us. I'm definitely excited because I'm part of the tech group. We've got lots of tech enthusiasts here, but more importantly, the other reason I'm probably nervous, but I'm going to say it's nervous excitement, is that all this tech is coming to us now based in primary care. So thank you very much for colleagues joining, and I can see we've got a really excellent agenda with wonderful speakers spreading primary, community, secondary care, just really to kick off tech across our regions. And before I go away, my name is Wakas. Oh, bit of feedback. Sorry for that. My name is Wakas, and I'm a GP, the primary care lead for the clinical network. And it is a pleasure to have a regional expert in the form of Dr. Peter Hammond with us, who's also the clinical lead chair of the Yorkshire and Humber Tech Group. Next, please. I'll just very briefly go on to housekeeping, and then I'm going to hand the floor to Peter. Obviously, like with any Teams meetings, please, just so that colleagues can hear the webinar and also for the speakers so they can focus on what they're trying to take us through. If we can just keep it on mute as colleagues join. The other thing is, if we do have any questions, sometimes we'll have a burning question or a query or a comment or feedback. Please do either put it in the chat function if possible, or at the end, we've got about 10 to 15 minutes for a Q&A. So please do lock those thoughts, write them down, do something, and towards the end, with the raised hand function, we'll have the opportunity to unmute and pose that question to the panel. So hopefully it's not just going to be a one-way flow of information. Hopefully it'll be a bit more conversational and more meaningful as well. And with that, without further ado, very briefly, the agenda I'll go through. I was going to pass it to Peter there, but I'll go through the agenda. So we're just doing the welcome introduction. Peter's going to kick us off and really give us an overview of, for those colleagues, this area might be new, what is continuous glucose monitoring. I'll very briefly touch on personally what I think why we should be doing this, and that's looking at a new cohort, moving away from type 1 diabetes and looking at tech in type 2 diabetes and perhaps some of the rationale. Very briefly, we'll go through how to do it. So we'll look at two devices, Abbott's Freestyle Libre and Dexcom ONE, just in terms of how to utilize it. So colleagues who this might be new technology to, they know what the device is, how to put it on, and what sort of support there is. We'll then have some wonderful speakers across the region who will give us some little golden nuggets around what has worked well and what I say is the learnings. So rather than us trying to be the guinea pigs, we can pick up some of that wonderful learning and share that and those sort of top tips, I should say, across the region. We've then got my partner in crime for diabetes in West Yorkshire, Hannah Bibber, who will take us through some of the resources that we've developed for West Yorkshire, but also some of the things that are happening in the Yorkshire and Humber Tech Group under Peter's chairmanship there. And then really to round it off, it's not just about HCPs, clinicians, tech. It's why we're doing this, and that is for the people where it matters, for those living with that condition. So hopefully we can bring, I'm going to say, as a flavour and some real experience, some lived experience there from two colleagues there. And then last but not least, all those burning questions, you can then start fielding them to Peter, not me, and we'll have a Q&A at the end. Hopefully that's everyone's got that agenda. Right, next please, Dan. Thank you very much, and I'll hand over to Peter. Please kickstart this.
Thank you very much, Wakas. So yes, I think, as you've said, this is really a primary care focused meeting, and so I'm keen that my contribution here is brief, but I obviously, as you say, I'm very happy to answer questions and things, and hopefully you'll have some questions that that I'll be able to answer in the Q&A later. So I'm going to give a really brief overview because I think you really need to hear from the people on the ground who are using the technology, both the healthcare professionals and the patients themselves, to get a flavour of just how important it is, I think, that we start rolling out continuous glucose monitoring in people with type 2 diabetes. Next slide, please. So I think that's just my disclosures. So just consulting fees that I've had. Next slide, please. So I'm sure many of you are well aware of what continuous glucose monitoring is. Next slide, please. But I think it is for those who aren't familiar or those who've got some understanding, but perhaps could do with refreshing it. I'm just going to show a couple of slides really to explain what we're actually measuring, because this is a bit different to just measuring blood glucose. What we're measuring, you'll see on the left-hand side of the picture, you've got a sensor sitting on the skin with the probe from the sensor going into the interstitial fluid. So this is sitting in interstitial fluid and not in blood. And essentially what it's picking up is exactly the same. The reaction that's being used to identify glucose is exactly the same. But it does mean that there are some differences which we'll cover in the next couple of slides. Next slide, please. So next slide, please. Yeah, so essentially what happens is that sensor sits in the fluid and when it has a glucose oxidase enzyme on it, which converts glucose, it oxidizes the glucose, and by oxidizing the glucose, it generates an electrical signal. And that signal is then transmitted to the receiver so that you get a glucose value. And it's exactly the same chemical reaction that's used to pick up glucose levels in the bloodstream on a blood sample. So it's what's being measured is exactly the same, and the strength of the electrical signal that's generated reflects how much glucose is sitting in the interstitial fluid. Next slide, please. What this does mean is that when glucose levels in the blood and the interstitial fluid are pretty static, then the glucose level in the interstitial fluid will pretty much match the glucose level in the blood. As you can see here, when the blood glucose levels are changing more rapidly, there's a bit of a delay between the level changing in the same way in the interstitial fluid. And at most, it can probably be about 10 to 15 minutes when things are changing very rapidly. So I had someone yesterday say to me, oh, well, you know, I felt hypo, I had my started eating to correct the hypo, and then my glucose level on the sensor said that the level was 3.2, and that just reflects that lag. So people have to be aware of that, and so there are just a few minor things, but essentially, to all intents and purposes, you're looking at the same thing. You're looking at glucose levels. Next slide, please. So Waqas has already alluded to the devices that we have available, and there are some that essentially we're obviously you're probably most likely to be familiar with Freestyle Libre, which was called flash glucose monitoring, in that you had to scan the sensor in order to be able to get a reading. And some people still use it that way, but you can now, if you've got the right phone and software, you can get the transmitter to send the data directly to your phone continuously. So essentially all these devices are now real-time continuous glucose monitors. In people with type 1 diabetes, we're often using more advanced continuous glucose monitors, such as the Medtronic G4 sensor, the Dexcom G6 and G7, and these can be used for hybrid closed loop systems. These are automated insulin delivery systems in people with type 1 diabetes, and they're a bit more sophisticated in terms of the alarms and things that they have. But essentially, they're all much the same. They all have very similar accuracy. You can use them on pretty similar sites, although the Libre is still licensed for use on the arm specifically. Some people do use it elsewhere. But the two that are prescribable are Dexcom ONE and the Freestyle Libre 2. So those are the two that you're likely to have more experience with, and Waqas is going to talk about those shortly. Next slide, please. One of the things that we're kind of changing in terms of our focus is, so rather than focusing so much on HbA1c, although that is still important, we're focusing on time in range. And you'll see here some targets for time in range according to whether you've got type 1, type 2 diabetes, whether you're looking at perhaps more relaxed control in someone who's older or higher risk. But one of the great things about this is that the person who's using the technology can see these things changing in real time. So they make a change to whatever they're doing, be it their diet or their glucose lowering regimen, and they can see immediately a change in time in range, which is really positive. Next slide, please. So at the moment, obviously, we've got a lot of people with type 2 diabetes who are using capillary glucose monitoring, so self-monitoring of blood glucose, which is quite a palaver for them. They're, each time you do it, you're having to take time to prick your finger, get some blood out. Sometimes you don't get as much blood out as you'd want. And for that reason, people often don't follow the recommendation in terms of capillary glucose monitoring. And people with type 2 diabetes are much less likely to follow advice about capillary glucose monitoring than people with type 1 diabetes. Next slide, please. And a lot of people, actually, there are some good studies that show a lot of the time people with type 2 diabetes become more anxious when they start capillary glucose monitoring because they're not quite sure what to do with the information. They don't like doing the testing, and so it's not a great thing to have to do. And this is where continuous glucose monitoring using one of these devices is much better. You put the device on, it lasts for 10 to 14 days. You're getting constant reads, you don't have to think about it again, and the information you get is a lot more detailed because you know not only what the glucose level is, but what direction it's traveling in. Next slide, please. So you can see here on the left hand side, you've got a glucose meter, so glucose monitoring with the capillary glucose, just saying these random spots where you've no idea whether the levels are going up or down. Next slide, please. And then you join them up with continuous glucose monitoring, and you can suddenly see what the trend is, and therefore you can adjust what you're doing much better to manage the glucose levels. Next slide, please. So NICE has recommended that for people with type 2 diabetes, we offer them continuous glucose monitoring if they're on more than one insulin injection a day and they've got any of the following. So problematic hypoglycemia, that can be recurrent hypoglycemia, episodes of severe hypoglycemia, or reduced awareness. If they would otherwise be advised to be capillary monitoring at least 8 times a day, or if they have a condition or disability, that means they cannot self-monitor with capillary glucose. And also for anyone with type 2 diabetes, where they need to do capillary glucose monitoring, but they can't do it without help from a care worker or a healthcare professional. I think that's really important for thinking about use in places like care homes. Next slide, please. And so I just wanted to finish with an example from my clinic yesterday. So this is someone who's 88, has had type 2 diabetes for over 30 years. And last time I saw her, she's on 3 injections a day, so a basal insulin, fast-acting insulin with her breakfast and dinner, which were the time she was measuring her glucose with her capillary testing. But she'd come in last time I saw her about 3 months ago with a significant episode of hypoglycemia on waking. And I felt quite worried about what was going on and whether she might be having unrecognized hypoglycemia. So we gave her a Freestyle Libre, and it showed a very consistent pattern of dropping overnight and then going up really after, not after breakfast particularly, but after her lunch. And as I say, I saw her yesterday, and we've been able now to address this much better because we have this information than we would have been able to previously. So I think this is really important information that we can get, which makes our patient management much better. Next slide, please.
1 minute remaining for the item.
Thank you. So really, just to summarize from me, we're increasingly going to be using diabetes technology in type 2 diabetes. This is an intervention which is user-friendly, of proven benefit in improving glycemic control and reducing hypoglycemia frequency in people with type 2 diabetes on more than 1 injection a day, and quite possibly those who are only on basal insulin. or indeed sulfonylureas. There may be examples there. It's simple to initiate. There are online training videos for how to use the system and interpret the data. And this information will help us to improve the care we give to our patients and the outcomes that they get. Thank you. Waqas.
Thank you, Peter. I'll just very briefly go through the next slide, please, Dan. I'm not going to take up much time, but I think I just wanted to share a personal reflection. So I think we're all aware, particularly clinicians. So if you look at the left-hand side of the screen, and this is just data from the RELIEF study, and I think we've already seen the benefits and the data and the evidence and everything, particularly for people with type 1 diabetes. Why, as you can see on the left-hand side of the screen there, their rates of complications are far greater. So if you look at the rates of DKA, hypos, hypers, coma, things like that. So adding technology to people who are at high risk, you could clearly see a benefit. And I think for me, particularly, what really changed my thinking and really brought me on board with actually people with type 2 diabetes would benefit would be if you look at the right-hand side of the screen. And if we look at the RELIEF data, this looked at about 74,000 people with type 1 and type 2 diabetes. And what they did was, and this is from France, they looked at the rates of complications, hospitalization, and so forth 12 months before the intervention, I given them technology, CGM, and then they looked at it, what happened to them based on that technology. And they had a few different subgroups, if you call it, of people or patients who were either not testing, so 0 test strips acquisition, a few might be testing 1 to 2, 3 to 4, and some testing more than 5 times a day. But what really made it fascinating for me was if you look at the percentage drops, yes, the event rates, so that is people getting complications or becoming unwell with that problem, like DKAs or hospitalization for low blood glucose levels, was low to start with. But on top of that, just with a simple technology, they were able to look after themselves better, identify trends better, and also you can see a reduction in hospitalization. And I think that was one of the big things for me, which is where it, and obviously now we have nice guidance to back all that up and gives us a bit of direction in terms of the use of this technology, particularly for people with type 2 diabetes. Next, we've just got 2 short videos, Diane, next please, that really just go through in terms of how to use, I guess, which device. So for colleagues where it might be new, it just gives you a very brief flavor. They're only about 1.5 minutes each, just to give you a feel of what the technology is without, if you're new to it as well. Maybe in a few seconds.
Now Sarah puts on the new sensor. Select the site on the back of your upper arm where you will clean it and let it dry. The Freestyle Libre 2 sensor kit comes in 2 parts, the sensor applicator and the sensor pack. It also contains a product insert. Peel the lid completely off the sensor pack and unscrew the cap from the sensor applicator. Place the sensor applicator into the open sensor pack and line up the dark mark on the applicator with the mark on the pack. Then press down firmly on the sensor applicator until it comes to a stop. Simply place the sensor applicator over the site you cleaned. Push down firmly until the sensor is in place. Make sure the sensor is secure after application. All that's left is to start the sensor. After you've downloaded and started the Freestyle Libre Link app, you will need to scan to start your new sensor. On the iPhone, there's an additional step. Once you've logged in or created a new account, the app will bring you to the How to Apply a Sensor screen on your phone. Tap Next. An image of a person holding the phone next to a sensor on the arm will appear. Tap Scan New Sensor. You are now ready to scan your new sensor. Hold your smartphone to the sensor to scan it. You will receive a tone and vibration after you have successfully started the sensor. Sarah can now get her glucose reading in 1 hour, and the sensor is discreet. It's similar to the size of a £2 coin. It's water resistant, so you can swim, shower, or exercise. The Freestyle Libre 2 system liberates you from the hassles of routine finger pricks.
Will then walk you through connecting your phone. You will need to enable Bluetooth and allow notifications. Enter your transmitter's serial number. The serial number can be found on the bottom of your transmitter box. Enter your sensor code. The sensor code is on the sensor applicator. Then the last step is to insert your sensor and pair your transmitter. The app will provide instructions on how to do this. To insert your sensor, choose a place on your belly or the back of your arm. If you are under 18, you have the option to place it on your upper buttocks as well. Avoid sites with irritated skin, bones, tattoos, or areas that get bumped. Before you begin, wash your hands. Then clean your skin with rubbing alcohol and let it dry. Peel off the adhesive backing. Place the applicator on your skin. Fold and break off the safety guard. Press the button to insert the sensor. Remove the applicator. You have now successfully inserted your sensor. Your sensor will last for up to 10 days. Now it's time to attach your transmitter. Clean your transmitter with an alcohol wipe and let it dry. Insert the transmitter. Tab first into the holder. Click the transmitter firmly into place. Rub around the patch 3 times. The transmitter is now attached. You'll reuse this same transmitter for 3 months. Back on the app, confirm you have inserted your sensor and attached your transmitter. Wait for your transmitter to pair and start the sensor warm-up. The warm-up will take 2 hours to complete, and you will not receive readings during this time. Keep your smartphone close to you, within 6 meters during warm-up. That's how straightforward it is to get started on Dexcom ONE.
Thank you, Dan. If we just go next, I'll just spend a few seconds and then pass on. Next, please. Next.
Sorry,
Thank you.
Wakas, is that the pathway? Sorry, I've got a bit of a lag, sorry.
I know, no, it's fine. Thank you very much, and thank you for the patience with all of us just seeing next. So this is very briefly, and I know that Hannah will go into this in more detail as well. This is just I'm going to say a proposed pathway. So some of this has been adopted and tweaked from Doncaster. I think it was either 22. They were creating a pathway as well. So some of it we've tweaked it around, and this is just as an example for where we think it can support both the uptake, adoption, implementation of technology, particularly in primary care, where we're often floored with all sorts of other workloads and work streams that we have to do. So it was just really to display this, and we've picked some elements of this in our PCN, in our practice, in terms of particularly some of the learnings or self, if you call it education, self adoption of the technology for people with type 2 diabetes as well. Next, please. So next we've got is 2 specialists. I'm going to say we've from different extremes. I'm going to say, so we've got Charlotte, who's the community diabetes lead for York and Harrogate, and will give us some flavors of from her side how she's seen some success stories and how they've been able to do some changes and perhaps share some good top tips. And then we'll also have Deborah Brown, who's a practice nurse at North House Surgery in Humber and North Yorkshire, who hopefully can give us some of her top tips as well. So over to you both. Thank you very much.
Thank you, Wakas. Yeah, so my name's Charlotte Simpson. I work as a diabetes specialist nurse in primary care in Harrogate, Ripon and the York area. So I think so my role absolutely is not to implement CGM, but it is to support primary care. So if that's a decision that a GP practice wants to take to start CGM, then it's my job to help them to do that. I think most healthcare professionals, when I'm going around, are saying, yes, they understand it's really useful, it's really beneficial for patients, but what is it going to mean for me? What is it going to mean practically in terms of workload? What do I have to do? It's worth saying as well, I noticed that Peter and Wakas mentioned both the Dexcom ONE and the Freestyle Libre. mostly we are using the Freestyle Libre, and the reason for that isn't because we're preferring that as technology. It's just that Abbott, who make the Freestyle Libre, are able to give us more support. So, and it's quite overwhelming for primary care to try and implement two things and learn both systems. So by going with one which we understand a lot more about in terms of the support available and we've been using more, makes it a bit more manageable. So if you're thinking about starting using CGM in your practice, think about your skill set, think about which practitioners are going to be using the Freestyle Libre. Look at the support that's around. So say, for example, you know, in York, there'll be myself and Nick. In Harrogate, there'll be myself. It'll be different across the whole patch. So utilize the support and reach out. There is obviously an upskill of knowledge. So normally when I help to support primary care, I normally go out, spend an hour, show healthcare professionals how to use the kit, what LibreView looks like. I certainly would encourage any healthcare professional who is thinking of working with patients on using a Freestyle Libre to have a go. It really helps to understand how the kit works, the practicalities of putting it on, unscrewing it, all those things. And as well as problems with its scanning. If you've done it, it gives you much more confidence to work with your patient on it. When we go back to Peter's slide when he talked about the NICE guidelines and the criteria, so it's not a huge amount of patients when you look at your patient population. So you're looking at patients who are on, people with type 2 diabetes, who are on 2 injections of insulin a day, and who would have one of those other things. So would otherwise be needing to blood glucose test 8 times a day. Hypoglycemia is a real issue. They have a cognitive impairment or a learning disability, which makes manual blood glucose monitoring difficult, or obviously if they would otherwise need a healthcare professional to be testing their glucose levels. So we don't recommend you doing searches. It's when you come across patients opportunistically and you think that this may benefit them. One of the concerns of primary care has been that they're going to have to start all these patients. About half of the patients that I start on a Freestyle Libre, they go on the live storming with Abbott, or they access it via a YouTube. So essentially a live storm is when they log on, we give them a link via the AQRX, and they can choose which live class they want to attend. There's one every 2 weeks. Abbott send out a sensor to the patient, and they can access it independently from their home. So we're not having to start everybody on a Freestyle Libre, and about half of the patients that maybe need a bit more support, we do face-to-face. I think it's worth, there's obviously starting the patients and it's reviewing the data, but also a real pitfall is not getting access to LibreView. A big thing is to complete the circle in terms of helping us as healthcare professionals reduce our time with patients. If we can see that data virtually, it makes a massive difference. So a big error that I did was going to a nursing home and start lots of people on Freestyle Libre, and the only way for me to be able to review that data was to go up to the nursing home, because they didn't have the telephone. They were using the Freestyle Libre device to scan. So just you will need the LibreView platform as well, and that will mean when a patient's on Libre, they will be sharing their data with you. So Abbott, who make the Freestyle Libre, will set up an account for you as a practice. So say, for example, your practice is Springbank, you will have a personal code for your practice and your patients will share their data with you. It's important that patients understand that you are not routinely looking at that data, that they understand that that data is only being reviewed when they see you or they're on the telephone. And if the patient does go through the live storm, then Abbott will connect them up with you. So you can have a dual share. So if the patient then is referred to secondary care, they can share their data with both you and primary care. But it's important that that share sits with you, or it gets confusing for the patient in terms of who is looking after their diabetes. It can be overwhelming when you first see the data. So if you're used to looking at blood glucose levels and then all of a sudden you have all this data, yes, it's brilliant, but it's also understanding what I'm going to do with that data. What are the next steps for the patient? So that's where I would encourage you to look at who you've got around you, look at the specialist support, look at Abbott, look at their support. Can anybody do these first reviews with you to help you navigate through those pages and make good prescribing decisions? For me now, I find it really difficult to make changes without Libre. You get so used to seeing all that data that when you go back to looking at blood glucose levels, you start to really worry that you might be missing, for example, what's going on through the night. So it's also worth noting that patients are able to self-fund. So if patients want to use the Libre but they're not eligible, they can still go on the live storming sessions. We just don't prescribe it, but they must get they should get their sensors through Abbott because it will be cheaper than trying to buy them on Amazon. And we need, when we're starting patients on Libre, if there's any tech issues, or if they've got a sensor that's faulty or comes off too soon, please, they need to call Abbott and not yourselves, because Abbott will send them out a new Libre, because primary care can't be sending, additional Libres just because they've come off too early or they're not working and they've got a faulty sensor. So I'm going to pass you over to Deborah, because Deborah is a practice nurse. So she's actually doing more of the bread and butter of what it's like being a practice nurse using CGM when you're already very busy and overworked as it is. So she can talk more the reality of using CGM and Libre and potentially Dexcom as a practice nurse.
Thanks, Charlotte. Hello, everybody. Yeah, I'm Deborah Brown. I'm one of the practice nurses at North House Surgery in Ripon. And I suppose I have the added advantage of having been a diabetes nurse and having used Freestyle Libre in the past, but it is a very different approach to being able to use Freestyle Libre in primary care. We've currently got 78 people on Freestyle Libre in the practice, and we have 52 people with type 1 diabetes, which means that we actually have quite a lot of people with type 2 diabetes already using Freestyle Libre. We do have people that self-fund. We've got people self-funding Dexcom and Libre, but the vast majority of people with type 2 diabetes are the ones that meet the criteria that we've already gone through. I think it does take quite a lot of time, and if I talk about the benefits first, I think we've already seen a lot of slides about how people's living with diabetes have much better glucose control. Psychologically as well, people feel so much better. They feel so much more in control of their diabetes. They're not constantly pricking their finger. They can see exactly what their glucose is doing when they go to work, do the shopping, have a meal, all the things that we would do without even thinking. Somebody living with type 1 diabetes has to take so much into account when they do that. So from a
2 minutes remaining on this item. Sorry to interrupt.
Okay.
2 minutes remaining.
2 minutes. Golly, right. Okay, I'll try and be quick then. So we really do know, because we've had particularly Libre for so long, we know how it works for people. The benefits for us, we can do remote consultations. People can ring up, we can see their Libre online, which is really good when people aren't well enough to come into the surgery. Much better use of the consultation. No more I've left my diary at home, so I haven't brought my blood sugar readings with me, and you've got a double appointment and nothing to talk about. It's got an HbA1c on there as well, so even if they haven't had their bloods, you've got an HbA1c. So I think nobody doubts the benefits in all of this. From a primary care perspective, the barriers are time, money, and staff. It takes me a double appointment to initiate and a double appointment to follow up. As Charlotte has alluded to, you actually need more than one person in the practice to be able to do Libre and interpret the data. It's not an enhanced service like insulin, and certainly one of my GP colleagues has asked me to raise the fact that will this become an enhanced service like insulin initiation when we take it on more frequently. The other benefit and barrier is care homes. Care of the elderly is very close to my heart, and I know Charlotte has already had some experience of initiating Libre in care homes. It is absolutely impossible to change somebody's insulin on a 6-monthly HbA1c and 1 post-breakfast blood glucose a day from the district nurses. So I think where this really helps us in primary care is the management of people in care homes, people with learning disabilities, and people who need help to manage their diabetes. We do need to look into things like training, which Abbott can provide, but also vicarious liability. There is a huge legal issue in care homes about non-trained staff actually inserting the Libre and uploading the data. So there's quite a lot to think about. We do have a pilot site in Ripon just about to go live, so it'll be very interesting to see what happens with them using Freestyle Libre. We have 10 people on insulin in that particular care home. What I would say is it's an enormous benefit to our practice. It really is. It does take a little bit of time to get your head around what you see on the screen, but there's so much support out there for both for us and for people living with diabetes. I haven't done a search. I haven't looked to see how many people might need Libre. I've just gone about it as part of the one-stop review. So if somebody comes in to see me about diabetes and identify that they might meet the criteria for Freestyle Libre, I discuss it, get them to go away, have a look at the stuff online, and then come back to me if it's something that they would like to try. But I think it would be pretty impossible to do a search and try and search everybody all in one go, unless somebody out there has already done that. This is how we do it here because it works for us, but I appreciate in other areas you may have different approaches which would be useful to share. Thank you.
Thank you very much, Charlotte and Deborah. That was very insightful and definitely poses us some challenges, some things to think about, particularly around care homes and around data sharing or integration, which I think is a common theme, but also in terms of, thank you for alluding to a lot of the support that's available, and particularly from Abbott as well, and I'm sure there's similar sort of packages of support from Dexcom and other providers there as well. Next is my diabetes partner in crime from West Yorkshire. We've got Hannah Bibber, who will take us through training. I think there was something around training education mentioned earlier as well. Hannah, over to you.
Thanks, Wakas. So hi, I'm Hannah Bieber, consultant pharmacist for diabetes in Leeds Health and Care Partnership, also West Yorkshire Health and Care Partnership. Next slide, please, Diane. Thank you. I don't know whether the slide wants to go forward, Diane. There we go. Okay, perfect. So pathway for CGM across primary care. So Wakas has already kind of given you a brief overview of this, but really we kind of need a way to flow people through the system sensibly and taking into consideration what their preferences are as well for some of this. And you've just heard a little bit of information there from Deborah and Charlotte on how that might be done. We probably want to have a think about how we also do check-ins with people, how we identify any sort of ongoing issues and how we kind of touch base with people in the interim as well. Obviously, people do have problems, you know, we need to be signposting them to some of the things that are available from the companies. And I think quite a lot of people don't actually know that some of those resources exist. So we need to try and embed some of that to reduce a bit of the impact on primary care. I think that's really the main concern, is that obviously when these things start, you know, we know ourselves how many calls we might get about Libres falling off arms. You know, these are the sorts of things that, you know, for primary care teams, if they're getting hundreds of calls, you know, this is not going to go well. So we need to kind of think about how we mitigate against some of this from the get-go. And then again, sort of how we then go on and refer to sort of MDT and specialist teams if we need to advance technology, obviously more relevant to a type 1 population. Next slide, please, Diane. I have to say I'm not loving this new Teams. I don't think anybody's loving the new Teams. So monitoring invitations. Obviously, we need to think about how we invite people in. So this was just an example of how you might invite somebody in with type 2 diabetes to be reviewed for this technology, if they're eligible. And I think Deborah mentioned about how do we do that from searches and things like that. Again, yeah, I agree, we're not there yet, but these searches are getting built, and it's how do we risk stratify, I suppose, how do we get searches that pull out sort of a risk stratified population, because as you've alluded to, I think that there's going to be rather a lot of people, and we need to have a bit of a strategy around who we do first. So this was just a way to try and get people kind of fished out and be able to use sort of a QR code in order to do that. Obviously, QR codes will only get you so far with certain people who are tech savvy. We have a lot of digital poverty, and so actually, you know, using a QR code is not going to get everybody, and we do need to consider how sometimes when we use this tech, and these sorts of quick, easy solutions, AccuRx is another example, they only work in people who actually have the technology to receive some of this stuff as well. So that's a big concern that we need to just keep in the back of our minds, I think. Next slide, please. So we need to think about what patient resources we've got, and we've done a reasonable survey of our clinical staff as to what they're using in a day-to-day workplace environment. This covers both type. This is actually, some of this is for type 1, obviously the Panther resources and things like that, and the Digibeat. So this actually incorporates a lot of our resources that we'd use in general for both type 1 and type 2. And this just gives a really easy summary that we'll be able to either copy and paste into clinic letters, or likewise hand people the copy of this document. And so Diane's jazzed this up beautifully. This is not how it looked when I handed it over to Diane, so it's looking really nice and attractive, and I think that will help people be able to just easily navigate how we can arrive at which resources we should be handing to people based on which technology they're using. The Freestyle Libre obviously has a plethora. In fact, it's taken up its entire own page really on all the resources available. In some ways, it is a bit overwhelming how many resources now we have for Libre devices, and which one do you use under which circumstances. So I think we need to encourage teams to familiarise themselves with the different offers, maybe even attend themselves so that they understand what each one might offer to different patient populations as well. But of lived experience for us as healthcare professionals never does any harm. So I think, you know, again, you know, carving out that time would be helpful. And the nice thing about Libre, just to pull that out, is they do have things available in different languages, which is very helpful in our more diverse populations, which we know are not getting access to tech in the same way that our English-speaking populations are. And then again, some resources there around hybrid closed loop systems and Medtronics as well. Next slide, please, Diane.
2 minutes remaining.
Thank you so much. So the education required is kind of 3 stages, really. Skills and expertise really currently sit with our specialist teams, and we need to start dripping that in to education and training needs for primary care healthcare teams, and start to address that. Having a wider range of practitioners in primary care with this technology will release a bit of the burden as well, I think, on the secondary care teams, and allow us to expand those new eligible populations, and also to mop up some of the type 1s that don't engage with secondary care as well, and which again tends to be our more deprived, more diverse populations. So healthcare professionals as well need to work, if possible, to a competency framework. This is probably more relevant to the more complicated technology, but certainly how do we do problem shooting if we don't know how to use it ourselves? So I think we do need to have some accountability. Sometimes we go and do education, but it's not till you actually use it, wear it, know what it is like to live with it. it starts to really make sense and it starts to translate into our clinical practice. Next slide, please. So developing different levels of competencies, we've kind of had a look at what sort of different levels we need to be working to. And I think there's sort of an unregistered healthcare professionals is definitely, and that would cover things like nursing home staff, etc. Competent healthcare professionals, this might be practice nurses, GPs, PCM pharmacists, it might be community pharmacists, for example, advanced level 1, FY1 doctors, etc. Competency level 3, that more experienced and proficient healthcare professional, maybe a more experienced member of primary care team, or likewise more advanced practitioner in secondary care. And then you get in that sort of senior and expert healthcare professionals around your diabetes specialist nurses, your consultant medics, etc. That are doing more of the hybrid closed loop technology, a bit more advanced and procured continuous glucose monitoring. Next slide, please. So just as an example, this would be competency 2. So we've kind of tried to pick out, this is a big document. This is just giving you a flavour of what's in here. So we've kind of had a look here about skills required. So we've kind of brought together what skills would be required for your general practitioner, and then on top of that layered that with what might be required within a specialist diabetes service as well. And that specialist diabetes service might sit in the community. There are areas in our region that have specialist diabetes services that sit in community, so that's another thing. Next slide, please. And then we've matched that then with resources and training to upskill yourself. So that just gives people, when they're doing their CPD, a really easy way to kind of go in and find the training that they need to upskill within these documents. Next slide, please. And then we've suggested ways in which people might want to assess their competency. So, for example, people doing observation of practice with another practitioner, for example, or developing some teaching materials for other healthcare professionals, might be doing some audit or research around some of this, might be implementing evidence-based practice around this with people living with diabetes. So there's ways to kind of demonstrate that you're competent in this. And this is an example for competency 3. So you can see it's getting a bit more detailed around kind of what level you'd be practicing at and what you should be holding your team, I suppose, to account over as well with regards to access and ability around this technology. Next slide, please. Oh, I'm finished. How wonderful. Thank you. Thank you very much.
Thank you very much, Hannah. It looks like there's a lot of training and a lot of education that we all need to do, particularly across the wider workforce that we've got in primary care. I think next, I'm very delighted that, in and amongst a clinical, if we call it, conversation, we're actually going to be talking about people. Patients, people with lived experience. So next we've got our two such members. We've got Chris Bright, who's the Community Partnership and Events Lead at JDRF. And he's also, interestingly, the founder of the Diabetes Football Community. So I'm sure he'll tell us about that as well. And he's lived with type 1 diabetes for almost 25 years. And alongside him, we'll have hopefully Marie. Hopefully I've pronounced that correctly for you, Marie, who is a patient engagement volunteer. She's retired and she has type 2 diabetes and has had that for about 10 years. So hopefully we'll get two different experiences. And alongside them, we might have other colleagues, maybe Lisa Holland from DUK, or I know Leslie's on the chat from JDRF as well. Over to you guys. And thank you very much for being here.
Bear me just a second while I share slides. Hopefully you can see that. And then there we go. Perfect. So thanks for having me along today. I'm going to hopefully be able to share a little bit of experience from a number of different hats that I wear. So I'm a person living with type 1 diabetes firstly, so hopefully again being able to link in my use of technology in there, but also hopefully being able to frame it into some of the organisations that I'm connected with and why they're important in the journey and the use of technology, I think, going forward. So my role at JDRF is Community Partnerships and Events Lead. So listening into the community, the Type 1 community specifically, to basically use their knowledge and what their experiences are to shape what we do as a charity to support them. And then also the diabetes football community, where I am the founder. And I'll touch a little bit on why that's important and why I think it helps with technology use a little bit later on, and obviously blending that into my personal experiences too. So to touch on the personal part first, I think this is a really important element to bring out into the choices that people with the condition make. The most important thing for me when I was diagnosed as an 8-year-old, giving away my age there, but was, can I still play football? And interest and engagement in interest with anything related to the decisions I made, the behaviours I had about my health and my healthcare choices for technology was massively influenced by the things which were important to me in life. And football, as an 8-year-old at the time, was massive. And it continues to have been something that's been really important to me throughout my life. So it's really had a huge part to play in the choices I've made, the things that I've done revolving around my condition. This slide hopefully summarises a little bit of the journey that I've been on with type 1 diabetes. I've been on mixture insulin at the very beginning, which when we're talking about technology at this moment in time isn't or didn't feel very technological. It felt quite rigid in structure, made life quite difficult in terms of flexibility and the things I was able to do. And I was on that into my early teenage years. I then moved to basal bolus regime. So this is where multiple daily injections and actually a bit more flexibility, where I would be injecting based on carbs and I'd be injecting for meals. And this, for me, when we talk about technology changes, still in the 25 years that I've had it, or coming up to 25 years, is the biggest technological change. So as much as we'll talk about CGM and the importance of that, this was actually the biggest change and that had the greatest impact on my life with type 1 thus far, until arguably now I'm almost on par with hybrid closed loop, which is obviously a continuous glucose monitor. So what we've been talking about, the Libras and Dexcoms of this world, connecting to insulin pumps and providing some automated insulin delivery based on glucose levels. So I've had that for a little under 5 months now, and it is a huge impact on my life. But as I already mentioned, the sporting story is the thing that really influences everything that I've done for type 1 diabetes. I've had the opportunity to do some great things in sport, but ultimately everything that motivated me to stay on top of my type 1 diabetes was because I wanted to be able to do the things that I enjoyed and the interests that I had. And sport and football and futsal for me were those really important elements of my life. So I think when we're talking about the reasons I chose tech, this is something that for me, from the age of 8 all the way through to the age where I'm at now, has been such an important thing. It's played such an important part in my journey, is that football and interest in sport, in what I do and the choices I make on technology. So I thought this would be an interesting one to sort of give you a view on what my views were on choosing technology and the things that have happened in the past, or my previous views about using diabetes technology. And when we're talking about obviously widespread rolling out of, say, CGMs or insulin pumps for people with type 1, and then arguably again now we're getting into that realm where technology is rolling into type 2 as well with CGMs. This is actually my choices of technology and holding back a little bit. We're actually influenced more by society and social differences or social views than actually the access itself. So, and something really important to consider in that. So sport mattered more. And then by coming into that, we're looking at football was a contact sport. I was worried about using insulin pumps as a result. I didn't want a CGM to be knocked off potentially. So I was a little bit apprehensive to begin with about getting onto that. And actually self-conscious and being and it pointing me out as different was quite a quite a big thing for me in terms of getting onto technology. So as much as it's about access, it is also about how that person might be feeling and the circles that they move and operate in. And equally, this word, stigma, the choices I made definitely influenced by stigma and stereotypes, and the sort of work that I do now is definitely heavily influenced by this, wanting to raise more awareness and wanting to change the perceptions, because those perceptions are the things which could hold people back from getting onto technology. And it certainly held me back for a time period of both using an insulin pump and, to begin with, thinking about CGM and the choices people make, because I know the benefits, and I'll come on to the benefits of why it was so important and the difference it has made. But equally, stigma is something that we have to tackle to ensure that people get the best treatments that they can when they can get them, when they're accessible, and they're becoming more and more accessible. So we have to tackle this alongside the access piece as well. I wanted to highlight this. This was a WhatsApp group that with the diabetes football community, so the peer support project that I run to connect people with football that are obviously living and impacted by diabetes. These are two different WhatsApp groups giving a view of what they're using in terms of technology at this point in time in their lives. So we've got an adult men's group and we've got parents and carers of children living with type 1. As you can see, hopefully on there, it's very interesting that parents and carers and children who are coming and being, diagnosed in the last few years are now very, very influenced by technology and are on a lot more technology than our adult cohort is. So it's going to be interesting to see how that flows through into, say, primary care and the interactions that you have, but something to be considerate of. And also, as I said, is it something to do with how our adults have grown up, their access as well as adults? How do we get more people onto technology in that cohort, because it has such a positive impact on their life and healthcare outcomes? So I'm now on hybrid closed loop. As I said earlier, the insulin pump talking to a continuous glucose monitor, and I wanted to bring out a few of the key things which have I've noticed from both hybrid closed loop impact and going on to that, as well as then what has continuous glucose monitoring done for me. So I've kind of tried to put it in brackets next to each one, but essentially it's made life easier. Certainly automated insulin and CGM have provided a bit of a comfort blanket. They're catching me when I fall, and I think alarms and trends have had a huge impact on that, being able to see my levels in real time. The insight that I've been able to get from the data that I wasn't available to me before in terms of fingerprint monitoring has meant that I'm better prepared to learn from the things that I'm doing in life, and also get into a position where I'm ready for the next time round. You can see hopefully on there about my HbA1c, which before I went on to continuous glucose monitoring was around the 65 mark. And then ever since I moved to a Dexcom G6 in 2018, 8 years, I think the highest it's been is 51. So there's no coincidence between that score and the change that I had available to me in terms of technology access. Ultimately, this tech is providing more time in my levels being in range for less effort, and it's improved my sleep, it's improved how I feel, recovery, how I approach life, mood, everything. And these are some of the other psychosocial impacts of living with type 1 diabetes, which having technology has really positively impacted, and I couldn't speak more highly of it. But equally, there is a number of barriers of getting there, which isn't just access. And as I've already mentioned, that's what I really wanted to get across here. And I think this is the kind of final thing from me, and the final point is about reframing that conversation to maybe tackle that part that we're not talking too much about, is in terms of stigma and stereotypes, which is reframing the conversation, getting people involved with others that are like them, and also connecting with interests and connecting with what people have in their lives, which is important to them. For me, football was a big thing growing up as an 8-year-old all the way through my adult life. I'm still playing now. But equally, there'll be other people out there where there's something else and equally or more important than, let's say, sport-wise. It could be a family member, and you can spend better quality time with a child because your levels are looked after better and you're not experiencing as many hypos or out of range moments where your levels are high. It could be work, super important, and it's variable times, and actually a continuous glucose monitor really helps you manage those changes in your routine. Whatever it is, I think being able to connect on interest before talking about numbers and HbA1cs and it'll get you a better HbA1c is really important in terms of motivating people and making a step towards getting onto technology. So whistle stop tour. I know I didn't have too long. Hopefully I've not gone over by too much there. And then hopefully you can find out a little bit more about what I get up to, both on social media, through JDRF, our website there, and also the diabetesfootballcommunity.com. And hopefully there might be a few questions at the end there. So thank you very much for giving me the opportunity to share that. And I hope it was insightful.
Thank you, Chris. Marie, over to you.
Hi, I'm Marie Tripley, and I am a type 2 diabetic. I've had type 2 diabetes for more than 10 years. And now in the past year, I've become a volunteer with Diabetes UK. So when I first started with diabetes, I was prescribed metformin. And the metformin then was, sort of getting stomach problems. So I went on the slow release, and I was having metformin in the morning and the evening. And then I had another drug put in with that called alogliptin. And for years and years, that was absolutely fine. And during that time, so in 2019, I first came across Libre Freestyle, and the reason I came across it was because of a television program, a Michael Mosley one on weight, and I thought, oh well, that sounds interesting, I'll give it a go. And it was interesting. So I found out things about myself and about the way that I interacted with food that I didn't know. So for instance, I could eat sort of new potatoes and it didn't make that much difference on my blood glucose level. But if I had baked potatoes, it did, or roast potatoes. So it was very, very interesting to see how my blood sugars reacted to different sorts of food. So I got the first Freestyle Libre free, and I think that still happens. They will give you the first one free. And then I bought my own, and they work out at about £48. So I couldn't afford to wear one all the time. So I'm just looking back, and they're very helpfully, when you go onto your account, they tell you how many you've had and when you've had them. And I had 3 in 2020, 1 in 21, 3 in 22, and 4 then. Now I've got a lot more, and I'll tell you the reason why. So as the years have gone by, I became I got stomach problems, and the doctors didn't know whether it was linked. Well, they didn't really seem to think it was linked to anything to do with my diabetes. But 18 months ago, it became so bad. I had immediate and sudden diarrhea. I used to have to take a kit round with me. It was really, really bad. So August last year, I was prescribed Creon stomach enzymes to see if that would help. That didn't help. Then I was referred in last September to a gastroenterologist, and actually the appointment for that is just about to come in now. So then I was sort of reading around things myself, and when I went to the doctor in December, I sort of said, could it possibly be metformin? So she said, well, it might be. So we decided then that I would stop metformin and go for a private scan, which I didn't need because it was transformational. Once I finished the metformin, my life changed, and you know, all the things that I thought were wrong with my digestive system and everything was fine. Now, if I had been if I didn't know about Libra, then I wouldn't have known what then happened to my blood sugar levels. And I put a Libra on when I stopped taking the metformin, and obviously I could see that my blood sugar levels started to really go high. And it was a bad time because it was December anyway, and you know, Christmas. And then by the time we got to the January the 3rd, I asked for an appointment quickly because I was getting greasy eyes, I was getting tingly feet. I could see on my Libra that my blood sugars were going up and up and up. So I had an HbA1c on my Libra at the beginning of 52, and it was going up to 64, and then at 73, that was at its highest. So I was prescribed, and I can't say it properly, but Dapa something or other, dapagliflozin. Anyway, I could still see, kept on wearing the Libra, and I could still see that my blood sugar levels were not under control. So I could then go back to the doctor and say, look, these are all my, look, you know, you can see all my graphs. There's so much information there I could show. And so I was prescribed glycoside, and then that really hasn't sorted it. And then I was prescribed to take it in the evenings as well. And now I'm beginning to see it's getting better. It's not as good as it was on metformin, but, you know, from just a patient's point of view, I can look and I can see that graph that's going along in the green and keeping it, you know, nice and level. I'm not going, and if I do go up, it comes down quicker. So I've been able to monitor that myself. And but if I hadn't had a Libra and I hadn't paid for it myself, and I know obviously from what I've heard, I wouldn't, you know, I'd still have to pay for it myself. But I had all the information. And for instance, trying to get any appointments is really difficult. So I'm waiting to have my bloods taken and my doctor, but I've got to wait till the 10th of April. If I'd have been waiting for bloods to be taken to find out what was happening, this would have just gone on and on and on. I know I'm taking control of my health, but that's because I can afford to do it. But at some point I've got, you know, I can't afford £48 every fortnight for a blood sugar monitor, but it's been so valuable to me, you know, going through this. So yeah, so at the beginning, interesting because I could see what foods were, you know, how it affected me, and really good for me now when I'm changing my you know, when the prescribing has changed for me. I can see now as well, talking about time in range, I'm 75% time in range, which is, you know, great. So that's my story.
Thank you, Maria, for sharing your I'm going to say your story, your journey as well. And it gives us really two flavors of slightly different conditions and how people's lives have been transformed. But thank you very much for coming today as well as sharing that. Right, next we've got is a Q&A. So if the panel can switch their cameras on so they're all visible, I know they're here, that'll be fantastic. And if there's any questions from the audience or even comments from colleagues, please do feel free to start sharing anything, and I'll just have a look at the chat. So I think one of the first things that came up in the chat function, which I think we've briefly covered, I think was just in terms of there's a lot more work to do, particularly around care homes. There are some, I'm going to say, is pockets of work, pilots, excellent work happening across the northeast. Charlotte mentioned it across Humber and North Yorkshire there as well. So I think it's how we perhaps at some point look at distilling and bringing that and possibly back here or somewhere just to support the vulnerable cohort, and also trying to tweak some of the concerns that or barriers that may arise within a care home around data sharing and things like that. Any comments from any of the panel? Because I don't think there's any questions coming so far, but I'll wait if there is. Feel free to unmute, ask a question, or pass a comment.
Sorry, I was just going to say, listening to Mairead, it made me think about a patient that I saw yesterday who he self-funded his Libre and dropped his HbA1c by 18 just by nothing other than him looking at no medication changes, just from him being able to identify what foods were driving up his glucose levels, and again giving that control to the patient, which is fantastic. So often when we start Libre, we actually don't make any changes. We start CGM and just see how patients progress. And also, sorry, somebody mentioned about to help patients to stay independent. The CGM has voice to speak as well, so it will actually read out your glucose levels. So if you've got a patient who's visually impaired, it can be really helpful to keep people independent for longer.
Yeah, I mean, so interesting there. Two things really from what Charlotte was saying. I think, you know, there are a number of studies that have shown that people get better control with type 2 diabetes when they've got access to CGM data, and usually without increasing the therapy that they're having. That actually a lot of it is around what it shows you about the impact of lifestyle on glucose levels, and that you're able to adjust lifestyle factors as well. So I think that's a really good point you make. And the other thing from Mairead's presentation, which I think was really helpful, is, you know, actually there may be a lot of value for some people in intermittent use of Libre, and we have discussed that at the network as a way of perhaps using Libre most cost effectively by letting people have periods of time where they can see what impact you know, and may be able to adjust their insulin treatment, for example, with type 2 diabetes, because we know that things tend to be more stable in type 2 than type 1 diabetes. So you may be able to make an adjustment, get the benefit, and then you know, not necessarily have to use it again for a while. And then if things start to you know, seem to go awry, you can have another period using it. So I think that's a really interesting way of looking about how we might most cost effectively use Libre.
I think going back to that intermittent monitoring, Peter, we've got quite a few farmers, and of course in this part of the world probably lots of us have farmers in the surgery, and it's lambing, and I've got a couple of farmers at the minute just using Freestyle Libre during lambing because, number one, they can't really wash their hands with the things that they're doing, and number two, they're probably out at 4 o'clock in the morning. So what scares them more than anything while they're out in the middle of nowhere is having a low blood sugar. So we're using it intermittently at times in their lives when actually blood glucose monitoring is quite difficult. They don't want to wear it all the time, but they like to wear it at times when they feel they're most at risk. So sometimes we need to kind of think outside the box a little bit, that people might not want it forever, but there are times in their lives when they would really benefit from it, and just having it available. And yes, we might take a little bit of a hit on the cost of the Libre, but it's better than hypos. It's much nicer for the person with diabetes, and then they can go back on it intermittently because they know what they're doing and they know how to interpret the data. So there are maybe more people out there who might enjoy intermittent use of Libre than wearing it all the time.
Just noticing there's a query in the chat from Paminda about medical legal guidance as to how often clinicians should be reviewing the data. It's exactly the same as capillary glucose monitoring. There's no, it's the person with diabetes in data and glucose readings, and there is no responsibility on the healthcare professional, the GP, to be reviewing that data from a medical legal perspective. Clearly, as I think you know, Charlotte was saying earlier, she now struggles to use glucose data unless it's continuous glucose monitoring data, and clearly it's really helpful in terms of making the consultation much richer, much more informative, much more helpful from both sides, but there's no medical legal obligation there.
Hannah, did your hand come up or went? Sorry.
I was mid-typing and then Peter addressed it, so it's all good. Thank you.
Yeah, no, that's it. Any other comments from colleagues? I think, Charlotte, what you said, it absolutely makes sense. I think it's, I always think knowledge is power. And at the end of the day, humans, I'm just thinking the way we are, we're like machines. So this is be self-learning. You're putting something on us, we're just learning a lot about ourselves, and then we're just making little micro adjustments. And there's obviously self-care, self-management, self-empowerment. And that's probably where we need to be for the NHS, but also for our own selves as well. But yeah. Right. I think if the questions are going to dry up, we'll give it one last minute. Any final comments, feedback, even from the panel itself, please do share that. And whilst you think about what you would like to say, I just wanted to thank, I'm going to say, is behind the scene, the Yorkshire Number Clinical Network team, Amelia, Dan, Caroline, everyone who's been able to put a lot of this together, even with the small little minor glitches that we have. Thank you very much for doing this, and more importantly, thank you for the colleagues for attending. Peter, I was going to leave you with the final word, seeing that you're the chair of the tech groups. I thought you should have the final word, please.
Thank you, Wakas. I noticed, Amelia, you had your hand up. Did you want to?
No, don't worry about it, Peter, but thank you.
And I'd just like to also flag up in the chat that Lisa's noted that there's a growing community on the Diabetes UK forum sharing experiences, hints and tips. I think it's really helpful. It's another resource that people can go to get the most out of these technologies. So just to flag that up as well. Thank you, Wakas, for giving me the final word. I mean, I'm really enthused by the number of people who've attended today, and I hope you've found that really useful. I appreciate that there are some challenges here in terms of getting skilled up to put people onto the systems, finding the time in our working lives, your working lives, to be able to help people get on these systems. But I think Deborah gave us a really good overview there of just what this can do to transform people's lives, help them manage their condition, and the challenges that we have in terms of how we deliver it, I think shouldn't let us not do that. So I think we need to make sure that we're not, the challenges we have don't act as an obstacle to us doing the best by our patients with diabetes. So I'd encourage you all to go out there, learn from what you've heard, and we will keep on sharing resources. Let us know. We'd be really great to have your feedback as to how you found the event, whether you'd like us to do more things, exactly what sort of things you'd like to do to help support you with getting people onto these technologies with type 2 diabetes, as well as the large number of people we now have with type 1 diabetes getting great benefit from these technologies. So thank you all very much for attending. Good that we finished a few minutes early, gives you a bit more time before you start whatever you're doing next, and we look forward to seeing you at further events in due course. Thanks everyone, and thank you to all our speakers.
Thank you, everyone.
Bye.
Thank you.
Bye.
Thank you. Bye.